Want to welcome everybody to this week's happy hour or Dermpath unknown session. Before I introduce our speaker, as is always the case, if you have any questions at all, you can go ahead and send them to education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com, and we'll get back to you very, very quickly. It's my real pleasure this week to introduce as our host Dr. Andrew Fischer. Dr. Fischer is one of our colleagues at Sagis Diagnostics. He originally bodes from the land of the Cornhuskers, Nebraska, and fortunately made his way down to Texas for undergraduate. He attended Rice University and then stayed in Houston for medical school, graduating from Baylor College of Medicine. He then did a dermatology fellowship at the University of Colorado, followed by a Dermpath fellowship at Penn, and is currently in Houston, where he splits his time between the practice of clinical dermatology and dermatopathology. And with that introduction, I'll go ahead and turn it over to Dr. Fischer.
Hello, welcome everyone. Thank you, Dr. Davis, for the introduction. This is my first time doing this happy hour with you guys, so bear with me. And if you have any questions about any of the slides, feel free to email me or Dr. Davis, and he can forward me the emails. My email is and Fischer is in my last name at sagisdx.com. So we have 12 slides that we're going to go through today. And we'll sort of approach the slide sort of in a similar fashion to how you would if it was presented as a new slide, and we can sort of discuss the salient features and the diagnosis, and maybe some potential differential diagnoses or things that you may be asked to differentiate this diagnosis from on the boards. So the first case, we have a punch biopsy, and at low power, you can see, that there's a lot of blood in the dermis, all this sort of red stuff. So, at this point, you can start to think about, sort of vascular type things, either vasculitis or a vasculopathy, or just for some reason the patient is having some hemorrhage. So if we look a little bit closer in this section here, you can see if we go top down, you have a little bit of hyperkeratosis, and then you have an epidermis that's very thin. And if we actually go and we look a little closer at it, it's not only thin, it's sort of dead and dying. The keratinocytes here are sort of pink, and it's really sort of losing its structural integrity. So that's not good, and it's not normal. And it sort of makes us wonder if the epidermis is getting enough vascular supply. You can see here in the center, it actually has lifted, so it's starting to form sort of a blister. So we know something is going on here. And if we go and look a little bit further down in the dermis, you can see, in addition to all of the extravasated erythrocytes, which are over here, if we go and look at the vessels, you can see that they are not patent, as we would expect. You want your blood vessels to be nice and open so the blood can flow through it. And in this case, we see that many of the vessels are clogged with this sort of pink amorphous material. And a lot of times, if you have blood vessel or red blood cells that are sort of forming a clot in the vessels, you can see the red blood cells. Like it might be sort of partially filled with the red blood cells and then partially filled with the fibrin thrombi. In this case, we sort of just see this pink material all throughout the vessels. And so that would be a pretty good clue to this diagnosis, which is cryoglobulinemia. And specifically, this is cryoglobulinemia type 1, which is the monoclonal type, typically associated with lymphoproliferative disorders. So essentially, you have too many of these cryoglobulins, which are like IgG or IgM, and they sort of congeal at cool temperatures and block the blood vessels. And in the skin, it can manifest as a vasculopathy with these sort of purpuric lesions. You could, suppose, have this happen to any organ, really. But this would be the characteristic finding. If you were to do a PAS stain, you would see that it may highlight these amorphous material, the cryoglobulins. Now, it would be a little difficult to differentiate this from other sort of thrombotic or vasculopathies. If in cryoglobulinemia, it really does form, as I mentioned before, this sort of like pink amorphous material. But fibrin thrombi and normal vasculopathy can look very similar. And so, in practice, you would have to test the patient's serum for the cryoglobulins, and that would help you to confirm the diagnosis. So other things to think about in this case would be, other reasons why the patient may clot, DIC, HHT, there are a whole host factor, the protein C, protein S deficiencies, all of those can form sort of a similar picture. And then if you can confirm that the substance is a cryoglobulins, then you know that this is cryoglobulinemia and not one of those other disorders. And then I also just mentioned that, the boards likes to ask about the cryoglobulins, of which there are 3 types. So this is type 1, the monoclonal type, is typically associated with lymphoproliferative disorders, and forms a vasculopathy. And then cryoglobulinemia type 2 and type 3, associated with other things, hepatitis, that kind of stuff. And that tends to present more with a vasculitis as opposed to a vasculopathy. So you actually see inflammation of the blood vessel walls with neutrophils, or you could have potentially a mixed picture with vasculopathy with vasculitis. But the pure vasculopathy, as we see in this case, is more with the cryoglobulin type 1. Okay, let's go to the second case. So we have, again, a punch biopsy. Let me straighten it out here. Look a little closer. On first inspection, things don't look that probably really that abnormal. So in that case, we can sort of start from the top down. You can see the stratum corneum looks pretty normal. Epidermis looks pretty normal. We look into the papillary dermis. You can see we have some dilated blood vessels here, some telangiectatic vessels. So that's one thing we've noticed that is a little bit abnormal so far. And then if we keep going down, you can see the dermal connective tissue looks pretty normal. We have our adnexal structures, the rector pili, eccrine glands. So everything looks pretty good there. So the only thing we see really is just sort of these widely dilated blood vessels, telangiectatic blood vessels. And then if you were to put this into context, it would be on maybe a female who is sort of covered in telangiectasias. And it may make you suspicious about a couple of disorders. And if you look closely at these blood vessels, you can see that there is sort of a thickened hyalinized membrane. And you may not notice that at first pass, but when you sort of study the slide a little more, you can notice some of these fine details. And if we do a PAS stain, which we have here, we'll go a little closer. You can see that it accentuates sort of that thickened membrane of the telangiectatic blood vessels. And so putting this together with a clinical presentation that I gave you would be consistent with cutaneous collagenous vasculopathy, which is a pretty rare entity, but has sort of a unique histologic picture, which is these thickened membrane walls around telangiectatic blood vessels on someone who sort of presents with generalized sort of telangiectasias. And actually you have, aside from the PAS, there's another stain you can do on this to confirm the diagnosis, which is collagen type 4. So it's supposed to be sort of basement membrane material that's forming these thickened walls here. So that's pretty interesting case. Okay, go to the next one. So case 3, we have again a punch biopsy. And, you know, just looking at this power, we have sort of a more or less, we have an infiltrate that's sort of filling the upper dermis, and it is sort of in a vague band-like appearance. It's not quite hugging the undersurface of the epidermis, but it is forming sort of like a semi-dense band. And so if we go a little closer, you can see that the stratum corneum is pretty normal. If we look at the epidermis, there's probably a little bit of sponge. You can see that some of these cells, which look like lymphocytes, are sort of extravasated into the epidermis in some areas. And then if we go and we look into the papillary dermis, you can see we have, again, these lymphocytes, these small sort of round dark blue cells. We have some histiocytes, which are these cells here, a little bit larger. And then we have a fair amount of extravasated red blood cells over here and over here, and really throughout. And if you put this biopsy on the legs, you know, say of an older gentleman who sort of developed an eruption of this kind of thing, we would say it's probably most consistent with like a pigmented purpuric dermatosis. And then, you know, of those, there are multiple types, of course, but with these sort of lichenoid type appearance, we would say this is, you know, sort of the lichenoid variant of the pigmented purpuric dermatosis of Gorgerot and Bloom, or lichenoid purpura. And one other feature that we don't see so much in this slide, but I will tell you is helpful if you do see it to confirm this diagnosis. While not specific, it still is helpful is to see hemosiderin that has been engulfed by macrophages or hemosiderophages. So essentially, probably you see it more in lesions that have been established. So as the red blood cells are extravasated into the dermis, they get eaten by the macrophages, and then they sort of exist there as these hemosiderophages. And if you see that, it's usually responsible for sort of the golden brown color sometimes you see in this sort of disease. And you could stain for it with an iron stain, and that would be another sort of feature you could use to make this diagnosis. So other things you might think about here, you know, with the sort of lichenoid type inflammation, you could of course think about lichen planus, But the thing that we don't really see that would be good for that diagnosis is sort of the dyskeratotic cells that you see with a true sort of lichenoid process. You know, we see that the lymphocytes get very close here, but they're really not sort of like hugging the undersurface of the epidermis. We don't see those dyskeratotic cells. It's not the greatest for lichen planus. You know, drug eruptions could look similar to this, although you might like to see, you know, maybe some mixed inflammation, a little bit more mixed inflammation. And then sometimes the pigmented purpuric dermatoses, you know, people talk about mycosis fungoides, and of course, that is a good thing to think about always. And if you were to see, you know, some of these lymphocytes that looked a little atypical, you could, of course, sort of pursue that diagnosis and look at the ratio of the CD4 to CD8 lymphocytes. Okay, good there. We'll go to the next one. So again, we have a punch biopsy, and at low power, you can see that there's a lot of hyperkeratosis, and there is hyperplasia of the epidermis. There's hypergranulosis, which we can see here. And then again, sort of similar to the last slide, we can sort of see this inflammation that's sort of really going along the undersurface of the epidermis, and is sort of throughout, but is probably most prominent sort of at the tips of the reedy down here. So here, 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 here. And it's sort of somewhat present up here, but a little bit less intense. And if we go and we look a little bit closer, let's find a good area to look here. We have the lymphocytes that are really coming up to the undersurface of the epidermis around here. There are some dyskeratotic cells here. So it does seem like we're dealing with sort of a true lichenoid type picture. And there was another feature I wanted to highlight. Let's see if we can find them. We have our lymphocytes. And there were some yeah, there are a couple eosinophils in here, which don't necessarily make or break the diagnosis, but it's just something to note. Let's look at the other piece. Oh, we only have one piece. Well, there were a few eosinophils in here, so if you guys found them, good job. So this, we have a lichenoid process, and we have sort of thickening of the epidermis with hyperkeratosis, hypergranulosis. So putting all this together, it is consistent with hypertrophic lichen planus, which, as I understand it, essentially is lichen planus that's sort of chronically like rubbed or irritated. So you sort of have like lichen simplex chronicus sort of superimposed on lichen planus. And typically, you know, classically is on sort of the lower legs, sort of exists as a big plaque. And unlike regular lichen planus, can have eosinophils, can have parakeratosis. Some people say that lichen planus should sort of not, in its purest form, should sort of not have eos or parakeratosis. But this can. And other things, that would be good to think about in this case, and maybe difficult to differentiate, discoid lupus, there's sort of a hypertrophic or verrucous form of discoid lupus that could look very similar. In discoid lupus, you would also maybe like to see some mucin deposition, but that's a little non-specific. You may also see some deep inflammation around hair follicles or the eccrine coils, which would be more typical of lupus as opposed to lichen planus. But that would be, something to think about in this case. And there are other tests that could be done if you are sort of stuck trying to differentiate between those two. You could do immunofluorescence and look for the lupus band test, or lichen planus has features on in direct immunofluorescence too, that could be helpful one way or another. And then the other thing just to mention in this case is that sometimes hypertrophic lichen planus gets confused with squamous cell carcinoma, because you have sort of these, you have this epithelial hyperplasia that sort of looks like it's going down, reaching down into the dermis. And you could get confused by sort of very well differentiated squamous cell carcinoma. So it would be important not to mix those entities up, because one is ultimately inflammatory, the other one is neoplastic. So for a squamous cell carcinoma, you would like to see some cytologic atypia and that kind of stuff that would help to confirm that diagnosis. But sometimes it can be challenging. Okay, so we'll go to the next one here. Turn it around. Look a little closer. Looks like we have what's likely a shave biopsy. It's trisected. And if we look just from this power, going from top down, we have some hyperkeratosis. It looks like it's probably a little scaly. The epidermis doesn't look that abnormal. I mean, there's probably some hypergranulosis. If we go and we look sort of into the papillary dermis, you can see that there is what looks like some inflammation sort of going along the undersurface of the epidermis. We can see that there are some apoptotic cells scattered about, and we can go look a little closer at those. And then the other thing to notice here is that the inflammation sort of tends to, it looks like it's sort of going along the undersurface of the epidermis, but also extending down this hair follicle, which is sort of interesting. So if we go and we look closer, you can see that there are all these sort of little holes in the basement membrane in the lower parts of the epidermis. So it looks like we have like an interface process going on. And that would make sense with these dyskeratotic cells that we see like here and here. You like to see that in sort of an interface process. Here's another one. Here's another one. We're really seeing actually quite a few of these dead keratinocytes, like here and here and here. And here's one way up here. Here's another one that's sort of higher up in the epidermis. So we actually really have sort of a little bit of a robust interface process going on here. And in this case, in some of these cases, you actually see some of these lymphocytes that are associated with the dyskeratotic cells, like here, sort of what has been called satellite cell necrosis. So that's something to note. More dyskeratotic cells. If we look in the dermis, we see a number of these basically like melanophages, just pigment that has sort of dropped down into the papillary dermis. Some more of those dyskeratotic cells. Okay, and then as I mentioned before, we have involvement of this hair follicle. So if we look here, you can see this inflammation that's sort of going down the hair follicle. Here, it's sort of chewing up the follicular epithelium as well. There's a dyskeratotic cell there. So at this point, we're sort of in the sort of interface dermatitis category, of which there are multiple entities, and sometimes they can be difficult to differentiate. Of course, you could think about lupus as an interface process, erythema multiforme, interface process, fixed drug eruptions, Stevens-Johnson's, and sometimes the clinical scenario can help to make the distinction between those. But in this case, with the amount of interface we have, the dyskeratotic cells that are fairly numerous and sort of going into the mid to upper layers of the epidermis, and the involvement of the follicular epithelium really is good for graft versus host disease. And so, of course, you would want to have the history that the patient has had, like a bone marrow transplant or something, to make that diagnosis. But this would be sort of typical for what you would see in that process, and specifically, in my mind, the involvement of the follicular epithelium, because you don't tend to see that. You suppose you could see it in lupus, but I'm not sure that it's really that common. And then you don't really see that as much in, like erythema multiforme or fixed drug, or Stevens-Johnson's. But again, there can be a lot of overlap in those conditions, and ultimately the clinical scenario sort of helps to make the distinction there. Just a few things about graft versus host disease. There are sort of there are multiple forms of it, and this sort of like interface lichenoid form is one, and then there's sort of a sclerodermoid form, and there have been like several other sort of described entities, but this is sort of a classic sort of presentation for graft versus host disease in the sort of interface slash lichenoid of the interface slash lichenoid type. Which I believe sort of presents a little bit earlier on, and then the sclerodermoid type with the thickened collagen is more sort of long-lasting, or presents a little bit later. And some people have even said that perhaps the lichenoid or interface sort of process gives way to the sclerodermoid sort of later on. I suppose it's probably different for each patient. Okay. So number 7, we have a shave biopsy, broad shave biopsy. From this power, we can see that there's something going on here in the epidermis. So it looks abnormal. And there's not a lot of inflammation. So if we go closer, you can see that so over here on the left, we have sort of parakeratosis, and then it sort of is giving way to some orthokeratosis. And if we look at the epidermis, you can see that there's sort of this pallorous change to the keratinocytes here. They're sort of like widely dilated, but very faintly staining and a little sort of like eosinophilic, and vacuolated looking. It's sort of as if you just sort of emptied out the cells. And then below that, and it sort of forms, sort of this like straight line across almost. And then below that, we have our epidermis, our sort of normal keratinocytes that look more viable. And there's probably a little bit of thickening or hyperplasia of the epidermis in total. And then we have, maybe some scattered inflammatory cells, but, perivascular inflammation, but not really that much to speak of in terms of the inflammation. So the main finding here is this sort of pallorous vacuolated change to the upper third to half of the epidermis. And this is a characteristic feature that is seen in a few disorders. You know, if you put this specimen on someone who presents with a photodistributed rash and sort of peeling skin, you would say it's pellagra. And that's what this biopsy is from, pellagra, or deficiency of niacin. But similar findings could be seen in zinc deficiency, or could be seen in the necrolytic migratory erythema, which is sort of the manifestation of glucagonoma. Can sort of all present with similar features. But in this case, it is pellagra. And this is sort of a characteristic look, and the patient would present usually with sort of a photodistributed rash, and the flaky skin that's sort of described clinically as like peeling paint, sort of just like peels off in thin wafers, and probably that's, you know, corresponds to this sort of change here. This area is just sort of, you're able to sort of peel it off. And if you replace the niacin, then they improve. Okay. So do the next one, number 8. We have a punch biopsy. And if we go and we look a little closer, you can see we have sort of collection of cells here just below the stratum corneum. You have a collection here, and you have a collection here. The epidermis looks a little spongiotic. You can see some white spaces there. And then we have sort of some scattered inflammation in the dermis. It looks to be sort of perivascular and probably also interstitial, and extending down somewhat into the reticular dermis, actually, not like the super deep reticular dermis, but sort of like, you know, down to here or so. So if we go and we look a little closer, we can see that these collection of cells are neutrophils, sort of look like little ants collected together. And so collections of neutrophils here and sort of on top of the epidermis or in the subcornea, subcorneal space would be forming what's called a pustule. So we have a pustular disorder. Here's another one here with a little bit of spongiosis. And if we go and we look down here in the papillary dermis, we probably have some edema here. It sort of looks pale and white. We have, of course, a lot of neutrophils. We have some lymphocytes. We have some histiocytes. And there were a few eosinophils here too. I had to hunt around to find them, so they weren't sort of all over the place, but there were a few eosinophils here too. We go down and we look here. We sort of have more neutrophils. Well, maybe this is an eosinophil. This might be an eosinophil here. But more neutrophils. This might be another eosinophil. So putting all this together, well, it could be sort of a few things, really. You know, if you put this on a patient who maybe just started a new medication and then erupted in pustules all over the place, then this you would say that this is AGEP, and that in fact is what this biopsy is from. So it's sort of like a pustular drug eruption, and that goes along with the collection of neutrophils sort of under the stratum corneum, and the sort of the spongiosis, sort of the dermal edema, and the eosinophils are all good for AGEP. But the other things to think about, you don't have the clinical history, say. Of course, you would want to think about an infection. You could have fungus or candida or bacteria that could form pustules on the skin. So you would want to do some special stains for that. Other things to consider, pustular psoriasis can look similar. Usually pustular psoriasis, you would like to see some psoriasiform changes away from the pustules. That would be good to see. You may not always see that, but certainly that would be helpful. Probably see a little less like dermal edema in that case. Probably don't see eosinophils. So all of those things you could use to sway your decision. Towards AGEP, towards pustular psoriasis, towards infection. Sten-Wilkinson is also something to consider here. IgA pemphigus. You need to do. You could do it. Immunofluorescence. All things to consider. But in this case, it is AGEP, and it's sort of substantiated by the edema we see and the eosinophils and the pustules. Okay. Let's go to the next one. Number 9. We have again a punch biopsy. And from this power, you can see that the features here aren't sort of really striking. If you look at the epidermis, it's sort of thin, a little atrophic. We don't see a ton of inflammation in the dermis. However, we do see that there's sort of something going on down here around the eccrine coils. So we can sort of take a closer look. We'll just start at the top here. You can see the sort of, not that much going on with the stratum corneum. The epidermis is a little bit thin. Maybe this is sort of potentially an older person. Going down to the dermis, not a whole lot really going on. But if we do look more closely at these eccrine coils, you can see that we have some inflammation here. And if we look more closely, you can see that there are sort of these cells that have a couple lobules to the nucleus. These are neutrophils. So we have some neutrophils around the eccrine coil, which you typically don't have. We'll go look at the other one here too. And again, you can sort of see that there are some neutrophils here, which is an unusual finding. We'll go over here. This is sort of even more exuberant over here. So yeah, a lot more neutrophils over here. So this would be consistent with neutrophilic eccrine hidradenitis. More or less, typically, it is a reaction to chemotherapy, where the neutrophils sort of collect around the eccrine glands. And usually the eccrine ducts are sort of more or less unaffected. So this is probably an eccrine duct sort of feeding into the epidermis. You don't see much there. This is probably another portion of an eccrine duct. You don't really see a lot of inflammation there either. It's really mainly centered around the glands, which are sort of deeper down here, and they're sort of seen as the collection of eccrine structures is usually is the eccrine gland, and the inflammation here is really in that case, or in this location. And so this, as I mentioned, is typically seen as a sort of a side effect of chemotherapy. And there are certain chemotherapies that are more likely to cause it than others. I don't remember them off the top of my head. Doxorubicin or cytarabine are the ones that come to mind, but you might want to look it up. But this is neutrophilic eccrine hidradenitis. Okay, go to the next slide. So we have a punch biopsy. It looks like, at this power we have really a sort of diffuse infiltrate in the dermis. And it looks like it's sort of, there are sort of multiple parts. There's sort of something more pale going on along here and sort of in the center. And then we have sort of these aggregates of darker blue cells sort of around the outside. But the whole process, the process as a whole really sort of fills sort of side to side and top to bottom. So something substantial going on here. If we look at the epidermis, it's sort of unremarkable. I mean, there's probably some epidermal hyperplasia, but not a whole lot to write home about there. So let's go take a look more at the infiltrate. So we have sort of these paler collections of cells, and then sort of these collection of darker cells. These look like lymphocytes. The paler collection of cells. Let's take a look here. Let's go in closer. And let's find a good place to look. So this is interesting. Here we have a lot of plasma cells, sort of this eccentric clock face nucleus, sort of this pink material. So a lot of plasma cells, tons of plasma cells. Here's a plasma cell that's sort of engulfed with some of the immunoglobulin, sort of a little pinker in color. I think they call that like a Russell body. Okay. So if we look at those paler cells, here's a good example of one here. It's sort of, they're filled with a lot of sort of this bubbly type cytoplasm. And then they have this large nuclei, like this is a good example here, that is more or less what's termed vesicular. So you can sort of see it's a little open looking, the chromatin is sort of open. It's not sort of like really compact like the lymphocytes. And it has a prominent nucleolus, which is sort of this darker structure. So that's a good example of the type of cell that we're dealing with. Here's another one. You can see it's sort of this really spread out, sort of grayish cytoplasm, it's sort of bubbly on the edges. And then you have these big nucleus with a prominent nucleolus, and it's sort of off to the side of the cell in general. And then this looks like a cell. This looks like, to me, like a plasma cell that's sort of existing within the cytoplasm of this bigger cell. And so that is sort of a characteristic finding called emperyopoiesis. And you think about that with this disorder, which is Rosai-Dorfman. And it can actually kind of be a little difficult to determine like where these sort of grayish cells end and begin, sort of like run into one another. But if you look closely, you can see that there are sort of these inflammatory cells that are sort of existing within the sort of grayish cytoplasm, which is, as I mentioned, is that emperyopoiesis. So this is very characteristic of Rosai-Dorfman. Rosai-Dorfman is a little bit of a cryptic disease process. It's pretty rare. Well, it's pretty rare in general, and then, you know, even more rare, I think, in the skin. A lot more, it's more often times seen in the lymph nodes, but you can see it in the skin too. Generally, you have sort of a diffuse infiltrate like we have here, and then you have collections of these really large cells with a sort of bubbly gray cytoplasm, when they have these big nuclei. And then you see associated with those cells typically sort of dense lymphocytic infiltrate, which is sort of those darker cells that we notice at the low power, and then a number of plasma cells. And then the feature that is nice to see is this imperiopoiesis, which you may not always see, and sometimes you have to hunt around to find it. But if you see it, certainly that's gives you a clue to the diagnosis. You know, one thing that is probably good to know about Rosai-Dorfman, if you wanted to do a stain to confirm it, you would do, if you could only choose one stain, probably you would do S100. And these big cells with the big nuclei should be positive for S100. Other stains you could do, CD68 should be positive, like a histiocyte marker or macrophage marker. CD163 should be positive. But if you were given the option of choosing just one stain, you would probably want to do an S100. All right. So that's Rosai-Dorfman, sort of an interesting biopsy. Okay, so number 11, or actually, sorry, this is, I think this is number 10, but we had that PAS that was added, so it sort of threw the numbers off. So actually, everyone that I've said after that PAS, you should subtract one number. Okay, so this is a shade biopsy. We have, well, it looks like we have a lot going on here, and we'll have to go closer to sort of figure it out. But even at this low power, you can see there's really something going on here in the dermis, sort of a nodular sort of process, really pressed up against the epidermis. Looks like the epidermis is sort of thin. And so we will have to go closer to figure this out. Okay. So here's our epidermis. And as I mentioned, it's sort of thin. It looks a little unwell. Maybe some of this is artifact from processing, but it's sort of very pink, some parakeratosis. We have a lot of inflammation that's sort of going and existing within the epidermis. And then we have really this nodule of cells that's sort of really pressed up against the epidermis. Sort of some white spaces between the cells. Let's sort of go and look closely at what they are. And we have, as you know, is common, sort of a mixture of cells, but we can sort of figure out, you know, which ones are more prominent. And certainly we have a lot of eosinophils here. We have some neutrophils sort of up by the epidermis. And then we have these other cells, which have sort of a purple to pink cytoplasm, and then sort of this darker nuclei. And the characteristic thing about these cells is that the nucleus is sort of curved, or so-called reniform, kidney bean shaped. You know, you can use the terminology that you want, but if you just identify that the nuclei sort of has this curved shape, it gives you a hint as to what the cells are. And these are Langerhan cells. So we have a ton of Langerhan cells. I mean, you know, sort of maybe a half or 40% of these cells are Langerhan cells, which is a lot more than we usually see. You know, you can see Langerhan cells in say allergic contact dermatitis, stuff like that, inflammatory conditions. But this is really, probably too much for that. So we have all these Langerhan cells, and some of these cells are sort of going right up into the epidermis, and over here they're sort of living within the epidermis, so-called epidermotropism of the Langerhan cells, and in combination with the eosinophils, this would be very suspicious for Langerhan cell histiocytosis, which basically is like a clonal proliferation of Langerhan cells that is essentially forming sort of like a neoplastic process. You have too many Langerhan cells. And so, the Langerhan cell histiocytoses are sort of an interesting group of conditions, and there are different types, and it would be good probably to know those. But for our purposes, we can identify this as too many Langerhan cells. And if you wanted to confirm that they were Langerhan cells, you like to see this sort of characteristic nuclear features. Sometimes you see a little groove in the nucleus, but it is good also to confirm on immunohistochemistry. And so the stains that you could do a CD1A, you could do an S100, and the most sensitive and specific immunostain is Langerhan, CD207, I believe. And if you have the cells that are positive for that, then it's without a doubt those are Langerhan cells. And then you'd have to do further workup after that to determine sort of the extent of this condition for the patient. The only comment I will make, Langerhan cell histiocytosis, of course, you see a lot of Langerhan cells, and you see the Langerhan cells sort of extrude into the epidermis, forming the epidermotropism. That's all sort of good for Langerhan cell histiocytosis, but you could also see a ton of Langerhan cells in eosinophils in scabies. And so like infants, for instance, sometimes have like sort of little papules or small nodules, and you could biopsy it and see a ton of Langerhan cells and eosinophils. And it might not be Langerhan cell histiocytosis. It could be scabies. You might not see the scabies mite. So it's just one thing to be aware of, especially like in infants. You could have a ton of Langerhan cells in scabies. But certainly this many would be very concerning for Langerhan cell histiocytosis, which is what this biopsy is. Okay. The next one, we have punch biopsy, or this could be part of an excision, I guess. We go a little closer. We can see we have sort of a thin epidermis, sort of some small hair follicles. And then we have sort of looks like the dermis and the subcutaneous tissue as well, looks very white, I guess, at this power. We have something going on there. We don't seem to have a whole lot of what looks like, inflammation. We do have some around the hair follicles here, but largely, we have sort of replacement of normal tissue with all this like white space. So we have to go a little closer to figure it out. And what do we see if we go closer? So this is, we're pretty close to the epidermis here, sort of in the papillary dermis or upper reticular dermis. And we see all of these white spaces forming little circles. And so that's sort of an abnormal finding. And if we go, further down, we see, again, just all of these little circles. Sort of looks like fat. But there's just way, way, way too much of it all around here, the little tiny circles. And all the way really to the base of the specimen. We can see we have those little circles, and they're really of different sizes. Some are larger, some are smaller. Some of this is probably normal fat. Some of this is the other process that's going on. So this has been termed sort of the quote unquote just Swiss cheese effect. and it is characteristic of a silicone granuloma or a paraphenoma. Basically, the patient has injected themselves or been injected with silicone or paraffin or something of that like sort of oil substance, and then as the tissue is processed, it sort of leaves this characteristic look. Uh, so you will see with time sort of more macrophages that sort of come and they sort of can eat some of this substance. But this sort of is characteristic for that process. Maybe the patient had some sort of cosmetic procedure done or something like that. It would, maybe give you this look. Um, I will, although this is a pretty characteristic look, I do remember on an in-service exam once they had a slide like this, and then the question that they asked was they had different options, and silicone was one answer, and then silica was another answer. So you had to know, you had to not confuse those terms. So silica is more like a mineral. It's not really like the same thing as silicone. Um, so just be aware of that. I had to think about it for a while on the test. But yeah, this is a characteristic slide. I wouldn't be surprised if you were to see it on a test somewhere. Okay, and the last one we have what looks like a punch biopsy. So from this power, we can see, we can, orient ourselves. We have a really, really thick stratum corneum, which is characteristic of acral skin. Also, we don't see any hair follicles. So that's also characteristic of acral skin. So we are sort of dealing with the palm or the sole. So that helps us sort of to put things into context. And if we go and look a little closer, we can see that this is probably, over to the side, sort of the normal stratum corneum. Should be more or less orthokeratosis, just stacked very high. And in the center, we have parakeratosis. You can see sort of all the nuclear remnants here. We have sort of a couple columns, like 2 columns of parakeratosis, which are sort of surrounded by the normal orthokeratosis. And then in the middle, we have, this looks like an eccrine coil that sort of was existing here, or the sort of the remnant of it going up. And then if we look at the epidermis, we have, off to the sides, this is sort of our normal acral epidermis. And we have our granular layer here. And then in the center, it gets very thin and sort of depressed. And it's a little hard to see for sure, but we're sort of losing the granular layer. So it starts a little folded on the slide. But we sort of go from this granular layer here to sort of losing it. You can see it here, we lose it. And then it turns into this parakeratosis. And then underneath of that, we don't really have very much going on. Not even really that much inflammation, just sort of normal dermal connective tissue. So this is a characteristic look of spiny keratoderma, or also punctate palmoplantar keratoderma. It is generally sort of a genetic condition, more or less, autosomal dominant, I believe, where you present with these little sort of keratotic growths, like multiple of them on the palms. And patients will just, sort of have it in their family. I think it can also present as a perineoplastic process. So if someone were to develop this condition, like say over 60, they didn't have it as a kid, but then they sort of got it when they were over 60. You may think about that they could have a neoplasm brewing somewhere else in the body, and they developed it as a perineoplastic process. But But most people who have this, it will be sort of a genetic thing that they have from a relatively young age. Okay, so that concludes all of the slides. So thank you for bearing with me tonight. And let me know, or let Dr. Davis know if you have any questions, and we can get them answered for you. Otherwise, take care.
Thank you. I want to thank Andrew for doing such a great job with those cases. And again, if you have any questions, let us know. We did have a question about the final diagnosis for slide 12, or for case 12, which was slide 12 on the presentation. And the diagnosis was silicone granulomas. So I hope that helps, Erica. And as Andrew pointed out, slide 13 was slide 13, case 12 was spiny keratoderma. So I want to thank you guys for hanging in there. Thank Andrew for a great job, and hope everybody has a great evening. Thank you.